Today really is meant to be very discussion-oriented, question and answer. And so we would ask people to use the chat function to ask questions. In certain cases, we may be able to actually unmute people for longer comments or questions. So please use the chat function if you've got anything to say. We appreciate a number of people had sent in questions that we've taken a look at, and we hope to be able to incorporate those into the conversation today. So thank you for sending those in, and we'll hopefully be able to bring those into the conversation. Let me just say a word about this this webinar and what we were thinking. You know, there is so much going on in COVID-19 with you know, its impact on our society, healthcare systems, public health, and so forth. That what I think we realized is that many people just would really like an opportunity to dialogue with folks who are thinking about and dealing with various aspects of the pandemic. So that includes, I suspect, all of you who are joining us today, and certainly our panelists that are with us. So so really that's the genesis of the webinar. It's really to provide a forum for people who are interested in just spending some time discussing some of these issues in more depth and learning together. So I think on the next slide, I want to say a bit about Comagin Health. Comagin Health was actually formed by the merger of two like-minded organizations, nonprofit quality improvement organizations, Qualis Health and Health Insight. We have over 400 staff with expertise in quality improvement, care management, health information technology, research evaluation, and analytics. And we work with state, federal, and local government agencies, health plans, and private funders, including foundations. And as you can see on the map, we're operating in over 13 states. On the next slide, I just wanted to comment. We have actually been directing work toward addressing the needs of various communities in various ways across the country in terms of needs with respect to the responding to the COVID-19 pandemic. We have been deploying our analytic capabilities to really understand where people are being impacted and helping to identify hotspots and anticipate where new hotspots might occur. We've been providing clinical consultation to different types of entities on the ground, particularly in congregate settings such as nursing homes, adult family homes. We now are becoming involved in contact tracing, really through a community-oriented approach that tries to help community understand the importance of the contact tracing and build trust in the process. We're providing infection control and prevention services and through trainings and education, and also have been providing training and consultation on telehealth and virtual services. So we've, for the last several months, we really have been focused on COVID, learning a lot, and some of that we're hoping to share with you, as well as hear from you about what you're learning. We really want to encourage people to submit questions through the chat throughout the discussion, so that we can we can broaden out our conversation and be inclusive in that way. So with that, I'd like to have our panelists introduce themselves a bit. On the next slide, I mentioned myself. I'm the Senior Vice President of Clinical Leadership at Comagin. Before joining Comagin, I spent over 5 years as the Chief Medical Officer for the Washington State Healthcare Authority, helping to oversee Medicaid and the public employees' benefits. And clinically, I practiced for about 21 years as a primary care internist at Harborview in Seattle. So I'm going to have the panelists introduce themselves here, maybe beginning with you, Jeff.
Hi, I'm Jeff Hummel. I'm the Medical Director for Healthcare Informatics here at Comagin, and joined Qualis Health in 2005 and have been involved in quality improvement, population health, primary care transformation work since that time. And over my career, I actually have spent a total of, I just counted it up, 35 years in clinical practice, starting in a rural Eastern Washington site and then moving to group health in a staff model HMO, and then worked at the University of Washington in the neighborhood clinics there while I was doing quality improvement work in those sites as well.
And John?
Good morning, I'm John Bassel. I'm a general internist and I serve as the physician executive for quality, safety, and equity for Comagin Health. Prior to that, I was chief medical officer for Swedish Health Services, which is the largest health system in the state of Washington. I also spent about 20 years in private practice as a primary care internist. Prior to that, like Jeff, I was at Group Health and also did some service in the HMO model, which has been very helpful. And before medicine, I was a bench microbiologist. So this infectious disease stuff is really up my alley. In fact, my research was on viruses. So that's my background.
And Sarah.
Yeah, thank you, Dan. Sarah Woolsey. I'm based out of our Utah office. I'm the medical director for system-wide quality improvement and have been working a lot with our infection prevention work, specifically in congregate settings like nursing homes, group homes, assisted living. I'm a family physician, practiced 20 years in the federally qualified health system, doing full spectrum family medicine, including nursing home care, and retain a home-based practice where we see patients at home. And again, very interested in this interface of COVID-19 layered on top of huge burden of chronic disease, and really looking, how do we do this going forward together? So thank you.
Well, thanks. So we're gonna hop right in. The way we're gonna work this is based on some of the questions that have come in, we were going to get the conversation started amongst our panelists and dialogue for a few minutes, and then begin to bring in the folks that are participating through chat, your questions, and broaden out the conversation. So with that, actually the first question is I'm going to direct at John. And really that's sort of setting the stage. And John, I'm wondering from your perspective, what has the pandemic taught us thus far about our healthcare system and about healthcare disparities in this country?
Yeah, thanks, Dan. Thanks for the question. And it's a very large question, so I'll try to keep my answer limited. First of all, with regard to public health, this is a public health crisis. COVID is a public health crisis. And what it has exposed is, first of all, I'd say an inadequate investment in public health. Our public health system has had a difficult time dealing with this, and it's not because of any fault, in my opinion, or on their part, or even lack of preparation, because we've heard Dr. Fauci say that they have been looking at the potential for a pandemic for many years. But the problem is that we have made an inadequate investment in public health. Since 2010, state public health department funding has decreased by 16% per capita, local funding by 18% per capita. There are 38,000 fewer people working in state and local public health departments. So that's the first issue with regard to public health. Second is that our public health systems are uncoordinated. We've got a federal public health, United States Public Health Services, which consists of a number of different branches. There's the CDC, Centers for Disease Control. There's NIH, National Institutes of Health. There's the FDA. There's Health Resources and Services Administration, Alcohol, Drug Abuse, and Mental Health Services Administration, the Agency for Toxic Substances and Disease Registry. So within our public health response, there are many different branches. And then we have 2,800 local health departments, state, county, and local. And as many people are seeing, unfortunately, publicly, there's a lack of a unified response across our various public health departments. So that's become evident. The third thing is that the effectiveness of our public health response depends on the credibility and connection to the public, particularly as we're seeing with disparities, because the public health services have to have the ability to communicate with the people on the ground where the problem is, particularly with regard to testing and contact tracing. And without that level of credibility in the community, the job becomes very difficult. And finally, there's this disconnect, as we're seeing, between the public health sector and the acute care sector, and the ability of those two sectors to communicate with each other and to hand off patients between each other. So those are the four major issues that I see.
So, and Jeff, thanks, John. Jeff, I wanted to continue to pick up on this, and particularly, John referenced the connection between public health and healthcare delivery. But, certainly we've seen an impact on healthcare delivery as well. And I'm curious your thoughts about, what that impact has been, particularly in primary care.
Well, the impact on care has been a combination of things. One, the first thing we noticed, of course, is that the actual operation of primary care has changed dramatically with a reduction of patients coming in to be seen, a switch to telemedicine services, and in many states there's been a very quick response to make sure that revenue switches to be able to support primary care practices. But it's very clear that primary care practices are stressed across the entire country financially, and in many situations, particularly in rural areas, their very existence has been threatened by the lack of resources, because of the fact that as we all know, the majority of the reimbursement depends on patients coming in to be seen. So that is, and that's altered our ability to really monitor quality. It's also changed the dynamic by which patients receive other services. So it's had quite an impact on primary care, and it remains to be seen how we adjust to that coming out. I think it's going to depend a lot on how we structure safe reopening of multiple aspects of our economy on the medical perspective. How do you bring people into the clinics safely, so that you're not, and how, particularly, how do we treat people who may have a COVID infection, who we know have COVID infections, or who are in for some other purpose? How do we take care of those people in ways that protect not only providers patients as well. But the economic impact has been very worrisome.
And Sarah, I wondered if you would want to add some comment, and particularly with respect to the impact on care gaps, people with chronic illness, and so forth.
Yeah, so I would just say two things. So if we're looking forward, as Jeff mentioned, what does delivering care look like and reopening look like, and likely a sustained need for the proper infection prevention, a flexible telehealth program that can, access the patients that want to do that when maybe cases are higher, if we see second surges in certain communities. So an attention to keeping in place many of the things that have existed, having patients feeling comfortable about accessing care when they have an established primary care setting, and then figuring out how to flex non-person face-to-face care. I think getting a system in place that has that just be the way we do business is likely going to be needed going forward. I think the second thing would be continuing to look at, and I really appreciate John's extensive comments on the public health, the need. So yes, there has been a gap in public health delivery, and where can health systems fill in appropriately. There's times when we're going to need to be self-sustaining to test our employees and our patients for COVID-19 to appropriately care for them when the public health systems see overwhelm. And so again, partnering for those niches that are important. And then the other thing I would say is COVID-19 has stressed all transitions of care, like as an infection that literally moves through the air and transmits. It's really honed our need for HIE tap-in. It's really honed our need for good handoffs such that the patients are not routed in the wrong direction, because that can be deadly. So I would just say that I think we're learning a lot that we can continue to do because we're going to need to do it likely for the next year, 18 months in those ways we deliver. It's different, and we've been doing some things really well.
Dan, I have one additional thought that came up while Sarah was talking, and I think I mean, we've been talking about what the short-term future response needs to look like, but I think what this pandemic has done is laid bare some of, as John mentioned, some of the weaknesses in the delivery system, just as it has in public health. And two of those, I think, which we've sort of skirted around, is that the reimbursement system for primary care, at least, and maybe for medicine in general, really is not adequate to handle the pandemic. And there's two parts of that. One is employer-based insurance is not adequate because, as we've seen, large segments of the population have lost their employment and no longer have insurance. And secondly, that the fee-for-service system, which was set up around office visits, since we're not doing office visits and providing care in other ways, we've had to scramble to make up for that. And I would argue that those two, which have been sort of the foundations of our reimbursement system, need to be seriously re-examined going forward.
Yeah, thanks for that, John. I wanted to come back to disparities, and you mentioned that the pandemic really has laid bare disparities that existed before the pandemic, both in terms of populations that have not been able to access care, in the time of COVID, and also the impact on people who had pre-existing disparities. The disease is differentially affects those people in that they can have more severe complications. I'm wondering, going forward, if you have thoughts about how we should be thinking about addressing those disparities in the context of the pandemic now. What can we be doing, having recognized that laid bare just how deep and wide these are, and how they're negatively impacting certain populations. Going forward, what could we do to mitigate that to some extent?
Yeah, again, thanks for the question. I would first start by saying that we knew that there was disparate outcomes in different communities in terms of their response to this virus, and that some communities were more severely impacted than others. It took us a while, actually. Of course, time has really changed in this pandemic. So a while is, in this context, is really just a matter of months rather than years, but it did take us some time to determine where those disparities were and why they were occurring. So public health had to make some shifts in terms of how they were gathering data. And you talked about analytics, and we'll probably get into that a little bit later. But the nature of the analytics have had to change a little bit just to recognize why there was this problem and where they were coming from. Over time, we've been able to determine some of the reasons for that, for these disparities. As Sarah mentioned, this virus is transmitted through the air, so we know that there are certain populations that are more exposed to the virus than others and are not able to protect themselves from it. So for instance, there are populations that are frontline workers, essential workers who come into contact with the public, service industries, nurses' aides, for instance, in skilled nursing facilities, who very directly come into contact with people who are potentially infected, and often those are in minority populations and immigrant populations. There are populations that can't work from home. They're not in jobs where they can do their job from a computer. There are those who can't do some of the processes that we recommend for prevention, such as hand washing. We know that in some rural areas and some Native American reservations that they may not have the sanitary facilities, running water, et cetera, for frequent hand washing. And many don't have quarantine facilities. We tell people, you know, if you're potentially exposed, to stay away from others for 14 days. Well, some people just aren't in a position to do that. Then going forward, we're looking at testing. How do we reach people to test those populations? Both people who are, both those populations of patients who are symptomatic and those who are not symptomatic, so that we can determine prevalence and hotspots of this virus in the community. Then with regard to care, as Jeff mentioned, some patients who have various kinds of illnesses, not just COVID, but COVID is a potential, they have symptoms and they think they may have COVID, do they have access to care? And as Jeff mentioned, there are people who already have pre-existing conditions, and they are staying away from care because of their concern about being infected in a healthcare setting, as well as perhaps not having the resources or the transportation, et cetera, to get to care. So these are all issues that have been unearthed by this pandemic. As you mentioned, going forward, we have to look at, I think, analytics. How do we analyze, how do we find those hotspots? That's one thing. Number two, strengthening our health department, and particularly its relationship with the communities, so that, for instance, contact tracers will be welcomed in the community and they'll get the information that they need without suspicion from the people who are being asked sometimes probing questions in order to find contacts. So those are some ideas that come to mind on that.
And Jeff, quickly before I turn it, start incorporating some of the questions from panelists, I want to pick up on John's point around data and analytics and how that can help, and maybe how it has been helping in terms of addressing the pandemic, and you might comment especially with respect to disparities, but more generally.
So thanks, Dan. That's a key question, and I think if there's one thing we have to keep our eye on, in this pandemic is what is the infection transmission ratio? Because if it's greater than 1, in other words, if each infected person is affecting more than one person, the pandemic is growing, and we're seeing that what that looks like in some of the states in the US, and that certainly was the dynamic that we saw in Spain and Italy. If it's less than 1, the pandemic dies out. And so every strategy has to be geared towards keeping that ratio below 1. And so then your analytic approach really boils down to looking at different communities which will have different dynamics going on. And it's not a single process. There will be communities in which there's no activity, and there your analytic strategy is one of doing sampling, cluster sampling, to see is there any activity at all? Because as we saw in Europe, it's very possible for the virus to spread throughout, go unnoticed, and then in a couple of weeks, it just boils up out of the entire, with community spread, as we call it. And at that point, your only choice is to shut everything down. And the goal is to identify amongst the places where there's very little activity, cluster sampling to see where the cases are. When you start to get cases, that's where the contact tracing becomes really important. And then the strategy throughout this, of course, is to use the interventions, so we can use stepped care interventions with the epidemic, just like we do with individual patient care when you have a changing situation. And so the analytics becomes really important to see where a community is in this progression. What you want to keep it from is keep away from that edge where you fall over and everything goes out of control and you've got these logarithmic rises. And because then you have really no choice besides the only thing that works then is to shut everything down. So I think analytics is absolutely essential to be able to gauge the health of a community, and this may be as a county or even a zip code when you start to see small outbreaks happening and be able to jump on them quickly.
Thanks. So I want to turn to questions coming in from folks participating today, and the first from Bob Perna, and actually, Sarah, I think I was going to sort of direct this one to you. And Bob writes, regarding the public health infrastructure, is the traditional county-centric model part of the problem? That is, does the model make statewide coordination of the pandemic response more problematic? And I know, Sarah, you have been dealing a lot with in Utah with both with the state as well as counties, and I'm wondering if you've got some thoughts about that, and what it's been like for you there, and what you might suggest if there were to be changes.
Yeah, so Bob, really appreciate the question, and I think it translates to national, right? National and state. So I think our some of the challenges John described is the transmissible, the way we move and the way this virus moves, it really is an international, national, state, county, and then local issue. And the way that things are structured, I do think that yes, county-centric models can be a problem, but that can be overcome. I think the different economic mixes, the different population mixes, the different factors in different counties can either bring resources to smaller places, or maybe smaller places are just naturally protected because of geography. So I think there's probably a balance in that. Yes, it's more challenging, and I think folks are learning from each other. I think there are places, we've seen rural areas really, they waited, they shut down their hospitals. They have an interesting type of capacity to reopen, let's say, if they haven't had as many infections. They have a different way to manage, let's say, a patient from a skilled nursing facility being positive. So I would say there's strengths in the different ways counties can manage it, as long as they're thinking about the whole. And I would just say also resilience of communities is geographic. And so harnessing the good of some communities ideally can message others and influence the larger community. But I think I would just say in general, coordination for this pandemic is needed. Resource coordination is needed. And so we need to model in our communities, our states, our counties, what we'd like to see happen at a larger level. I tend to be kind of a, let's look for the positives. Let's model those places where things have gone really well. Many of us have looked at Illinois. They did really have a strong statewide response. It was challenging. And there are definitely results in their data that show they were able to reduce that transmission in their community and then slowly open up economically. So again, maybe the good news is that we do have examples elsewhere we can model and maybe more quickly learn from. And then Jeff, Jan, you asked about my state. We've had some coordination in particular areas and less in others. It brings lots of learning opportunities.
Great, thanks. And so question from Richard Kozel. In chat, COVID requires a very personal living strategy for each person and family household unit. Many have not been successful in optimizing a strategy. How do we help them? What are the roles of public health providers, medical care providers, social service providers, and the educational and transportation systems? That is a great question. Let me maybe go back to John and see if you wanted to comment on that.
Yeah, let me unmute. That's obviously huge. And the problem, as I mentioned, with regard to disparities particularly, is that not everybody has the resource or the capability of implementing some of the recommendations and optimizing the strategy as is noted. One particular area that we have in King County and elsewhere, I'm sure, is the problem of homeless people as an example. They are often living together in crowded conditions. They don't have sanitary facilities. They can't really quarantine, at least not on the street. So social services has been a great help in that regard. They've been able to, I'm going to use the term commandeer some hotels, get people off the streets, put them in situations where they can have access to soap and water and quarantine themselves. So there's certainly an important role for social services in that setting. It's a little bit more difficult when you have people who live in multi-generational families, for instance. Some public services may be helpful for that, but very often people are just required to sort of quarantine themselves as a unit, as a family unit. It's not ideal, but it can be life-saving.
Can I just add? I mean, Richard, I think, again, given what COVID-19 has brought to us, we know that we need to make available a setting where people can convalesce away from others they could give an infection. And that's the outcome that all those listed, public health, medical care, social service, education, transport, we need to ideally move to that end to reduce, transmission and help people recover. So, I think we've got to be thinking about a structure that allows that to happen for each individual, ask them if they can execute it, and be trying to think ahead. I know one community in Utah was proactive in using dormitory space that was evacuated because students went home. That's a resource. That's a state resource. Could that be used and have people feel comfortable in that space? I think that's the second piece is, will someone even go there to convalesce? But let's drive toward that. I think we know what it looks like, and then what are the creative ways to make it happen? Each community is somewhat different, but we know what is needed to be done, and we know that we can support people to do it, but it takes certain things. So my thought would be, that's the outcome. Where do we have the space? How do we make it accessible to the people that need it and put the funds toward it? I have watched my state, and we've watched and learned a lot from Washington State, here in Utah, COVID positive facilities, right? A nursing home if it holds beds for patients that are convalescing from a hospital stay with COVID-19, it requires that someone pay for the beds that are waiting for those patients to come. And so we need financial structures that can support the end goal that is the right goal for each sort of step of the way. So, you know, I think your question is great. I think there are models that are working. How can we reproduce them and then fund them from the funds that are coming federally, state, or privately?
Yeah, and Richard, I would add, as I think about it, in some sense, I think, you know, so we have never done a very good job of coordinating services across these sectors, right? And I think perhaps, and speaking as somebody who has been a medical care provider, healthcare systems in particular sometimes are very siloed from their communities. But you know, the idea is then, and what I think this is the pandemic might be driving us toward is what structures, what capabilities do we need to create in order to allow better coordination. And so I know in this state right now, and particularly in King County where I am now, there's a lot of emphasis on building out a community information exchange. The idea that that across these sectors you could make referrals in a much more facile way in terms of first being able to identify a resource that could help somebody to implement a personal living strategy, and then making sure that you get them connected to that with so-called closed loop referrals and so forth. So I obviously the going back to where John sort of began the conversation in terms of the underinvestment in public health infrastructure broadly, I would say this represents an area that has not been well invested in. But I see that at least in some communities that the pandemic is driving new strategies to allow better coordination and involvement of the sectors that you're mentioning here. So there's just another thought. I want to encourage people again to feel free to put questions into chat. We've had a few good questions. I've got some more here based on those that we called when people were registering, and actually we've talked some about analytics. What I'd like to do is maybe talk a little bit about infection prevention, and I suppose that the question is what have we learned and what are we changing as a result? Again, I was going to go to Sarah again because Sarah's been doing a lot of work in this space. So with respect to COVID infection prevention, how have things changed? What do we need to be doing differently?
Okay, so I'll give a shout out to my awesome infection prevention colleagues out there who, including my mother, who always said, wash your hands, right? I feel like their day has come where all the things they've said for a long, long time are really hitting a finer point. I feel like a lot of the bread and butter that we've talked about for a long time, more people are doing, thankfully, more people are thinking about. And the question is, can we sustain it? Can we make it business as usual? And I mean, that includes going out with a mask on, right? That's infection prevention. And as a culture, we've really shifted the things we've known have worked a long time for respiratory diseases are now talked about all the time. So I think that's exciting. I also think that obviously it's been said already, not doing the care that's needed with someone that's not face-to-face, we have seen a rapid explosion in that opportunity. And it really works for some situations. It doesn't work for other situations. One of our patient family advisors was dealing with a health issue and has a transportation challenge. And she said, this is the best thing that could have ever happened to my, really severe diagnosis, is that I could see my practitioner on a televisit. This solved a solution she's had for 20 years. So I would just say that that rapid explosion in some really positive things that increase access for folks, in terms of telemedicine, put in those solid principles of infection prevention and just make it that's what we do all the time. I think those are a couple of positive things that we'll see sustaining going forward. Now, the caveat is we need to have the supplies, the space, ongoing training, and I would say for telehealth, we need the reimbursement that allows it to be sustainable, and know that the quality is good, and begin to think about that. So that's a couple thoughts I have, Dan.
That's right. And Jeff, would you want to add something?
Well, I think everything Sarah said is right on target. I mean, we know that masks work. We know that washing hands work. We know that social distancing works. What's challenging is the term social distancing means different things to different people. And we all know what it's like to be in a supermarket and have people have different ideas about what that means. In fact, I've been to the different stores in the same chain and been told, no, you can't do this, and other places say, oh, you're supposed to do it that way. And what I think we need to start thinking of is how do you engineer social distancing into the visual messages? And this gets to the question that just came up in chat about commenting about guidance returning to school and things like this. How do we engineer, just as we started to build bike pathways so that people know where the bikes are supposed to be, where the cars are supposed to be, how do we engineer into our work environments, into our school environments, the visual cues so everybody understands what to do? Because most people are trying to do the right thing. I mean, it's when someone is crowding up against you in the supermarket and you want to, there's this emotional thing where if you have to tell them to back off, it turns into this like tension. And if we just all understood exactly, so my daughter works in she's a performing artist and is in a rural place where people come and visit, and they have these things set up, which are visual cues, which are fun. They're like things like LED lights or sparkler things that lay out where the visitors get to be and where the people who work there are. So everybody is distanced. And there's no reason we can't make the social distancing in schools fun and playful. There's no reason we can't be very clear in our workplaces so that people channel through their common areas in ways that keep their distances. And I think we're starting to see that, but I think we really need to explore that engineering aspect of it much more.
And so, I want to pick up also on Pam's question, and you were talking about the social distancing and actually, ways to build that into the environment and obvious relevance to schools, and just to read it here, Pam writes, wonder if you guys want to comment on the situation or situation of a lack of clear guidance with safe return to school for staff and kids. And I think the first comment is, unfortunately, this is such a essential topic for our country, and unfortunately, the discussion has become highly politicized and moved away from really trying to be evidence-based, and recognizing the tensions that need to be balanced here, in as much as smaller children in particular, and the import of their being in school for many different reasons, as the American Academy of Pediatrics has specifically spoken to. But on the other hand, the need for doing that safely, both for kids and as well as for the adults and the teachers in classrooms. What I would say is that actually there is a body of evidence. It's limited but growing, that could help inform clear guidance if we were able to move away from we just got to do this kind of an attitude, and really begin to think about what we know and how we can use what we know to create the most effective strategy. So, for example, and I would reference this, and maybe we could put this up for people. The University of Washington actually just published a really interesting study on what evidence there is around safety for kids in school. And a part of that, for example, is just the observation at this point, not, I think, definitively proven, but that smaller kids are much less likely to transmit COVID, even if they're infected but asymptomatic. So there's sort of epidemiologic findings like that need to be need to be combined with, I think, some of the behavioral aspects that Jeff is speaking to. So it's unfortunate that we're at a point where we can't. I don't think we're having the right conversation in terms of what is the evidence, how do we continue to build that, build out that evidence, work with it in terms of informing policy. And Sarah, I'm wondering, as a family doc yourself, whether you have thoughts about this particular question as well. So important.
Yeah, I think it's really important. I don't want to forget. So it's tough. We're facing the timeline of school because school starts in the fall. I do want to, have us remember that if we can shut it down, kids can safely return to school in communities where there's not significant transmission. So I don't want to forget. There is an element of what we've seen work in our own states and other states that, we need to reduce transmission. So there is an element of a timeline that we're facing because school starts in the fall. And, we may need to look broader at just the continued effort. How do we shut this down such that kids safely go to school and teachers safely go to school because spread is down? So I don't want to forget the element of that public health response that we maybe haven't met everywhere. But going back to then, we're going to have to be creative and flexible. And I think we need to really assess, is there anything that has worked that's acceptable to families? We need to respect rights of teachers. We're going to need hybrid models. We can't have an absolute answer, and we're going to change our minds at times. And what is the way to sort of share those best practices and get the funding to implement them quickly when they show they do work? That would be my added comments.
Thanks, Sarah. So incredibly important topic that I'm sure we'll all be following. So there's a question from Sylvia who asked, and I see if any of you guys want to take this one on. How do you think the new directive to have all data go to a private technology firm instead of the CDC will impact the medical community's ability to care for patients and anticipate issues that come up with respect to available protective equipment, rising infections, et cetera?
Boy, it's hard to imagine how this is going to make things easier to function. I guess the question is, what do we do? And I think it brings out the importance, and this has come up in one of the questions, and John certainly alluded to it earlier, the importance of forming strong linkages on a regional, state, and local level between the public health and the delivery systems and the community. I think we need to, we haven't gotten a lot of leadership nationally. I think we all recognize that, and that's been one of the challenges that we've faced. So if you compare the way that Spain, for example, which had a disastrous beginning because they got completely taken by surprise by the severity of the pandemic, and yet the response was entirely centralized. And even now, now that they're out of the acute pandemic phase, the public health departments are being directed centrally, and yet they're being run locally so that you can identify the weak spots and fortify them. So that's what we need here. It's hard for me to imagine how taking the CDC out of the current mix is gonna help things. And I think probably what we need to be thinking about is how do we compensate for that on more regional and local levels between our health departments and our delivery system. So for example, I do know, I was just on a call the other day in which I learned that Epic Systems is talking to CDC about direct feeds from their EHR to the CDC. Now, I don't know how this new ruling will change that, but the point is that there's no reason that reporting still can't go through state health departments, and that coordination between the state health departments, the regional delivery systems, and the community resources, which are so important, as we said, can't all be coordinated because that's what's essential.
Thanks. So we have actually two questions from Chris Hollis. One that I apologize, Chris, I missed, or I think earlier on, but actually I think it's going to make a good closing question. So I'm going to ask, I was going to sort of go with your most recent question, and then your earlier question, maybe as for basis for maybe some closing out kinds of thoughts. How do the physicians on the panel feel about the move, partially attached to value-based payment, to having primary care providers providing care in team structures and using community health workers / navigators to connect patients with social needs to social service or other structures that can help with these?
I will just say, as a federally qualified health center physician for many years, that it benefited my patient to get the right care that wasn't always me, because it was delivered by someone who had a synchronous background or language or understanding of a situation. I think it's phenomenal. I think that dispersing, right care, right person, right time into those systems that are supported by value-based payment is exactly what we need to do. And I think if we can show the gains from it, we can show the positive responses to it. I know in our communities, successful screenings for our highest risk populations are advocated and spurred by community health workers and those organizations. So again, at every level, it's trust, it's partnership, and yes, allocating resources to right person, right care, right time. That is what you described there, and I think COVID-19 is showing some positive results. I welcome John or Jeff to also comment.
Yeah, I would just add that we've heard the argument, at least some of us, that the United States spends a lot more on their more GDP on healthcare than European countries, and less on social services. But the net seems to be about the same. So we've sort of medicalized social services, whereas other countries have separated out the social services from their medicine. So we have many people presenting in a medical setting who actually have a social problem that can be solved in a different way. So one of the advantages to this structure is it helps to, as Sarah is saying, direct people to the right resources, which may not necessarily be medical resources for the problems they're having. So certainly this would be helpful.
Yeah, I might even go a step further, and Chris, in thinking about your question here, and actually, where we began with John's comments, because which is our in the Don Berwick it says the systems are perfectly designed to get the results that they get in terms of how the pandemic particularly has adversely impacted primary care. So at a time where you could argue you need primary care the most, it is stressed and in some places imploding because it's not financially viable. And I just wonder if prior to the pandemic, if primary care at least had been entirely capitated with payments that were to include a goal of promoting optimal health, so that there was value for a practice to actually create systems and connections with CHWs and navigators, whether we would find ourselves in a much different situation today than we are. So you brought up parenthetically value-based payment, and I'm sort of taking that to a particular what I would call value-based payment approach, and just how different things would be perhaps if we had used value-based payment in that way prior to the pandemic. So just cognizant of time here, and I and of course now as lots more questions coming in as we run out of time. So I did promise Chris that I was going to get back to his first question that I missed, and this might be a good one for people to close out on, but just with a brief comment because we only have a couple more minutes. But Chris's question was, what do the physicians on the panel see as the key attitudinal and/or political system barriers keeping the public medical, healthcare, social services, health insurance, or payer sectors from working together, collaborating? And I might broaden that out just to, just generally what would it take to, to drive better integration across those entities, political or otherwise. So maybe, I don't know if you each want to comment, John, beginning.
I'll make a brief comment. First, I want to start with what I hope is a positive comment. Jeff Hummel talked about the R0 or the R0 number previously, and that's the number of infections that are caused by additional infections potentially caused by an infected person. The interesting thing about this virus is, you have some infectious agents that are highly contagious, but they're not particularly serious, like the common cold. You have some that are very serious, but not particularly contagious. So for instance, leprosy. You could live with somebody for years with leprosy and never actually get it. The thing about SARS is that it's both highly contagious and very serious. And that's why we're in this predicament. And I bring this out because I don't think we're going to be in this predicament all the time. We're not always going to be socially distancing. We're not always going to be wearing masks. Hopefully, we'll reach a point where we won't have a serious infection that's highly contagious in the community. And I think if people got used to that idea that this isn't forever, that we would probably have more cooperation. So let me start with hopefully a positive thought.
Yeah, no, that's a great thought, Sarah. So you've got about 20 seconds Sarah, if you want, and you're on mute.
And I would just say, for me, it's alignment to what the outcome is that we want from the community, and looking at that and saying our scientific argument matches the economic argument that we want to see. So if we do this, we'll get that return, and alignment on the outcomes that we want to see, and looking at the big picture of where the science and the health messages and the economic message, lining those up, and have everyone just follow in step to move toward that common goal.
And I would add to that, and I'm going to, Jeff, do you have a quick word?
I just think we need to be very clear about what we think the delivery system needs to look like if it's going to handle the next one of these properly, which I don't think we did this time or have this time. And that's primary care based, integrated with community health workers and community and public health. I think the three go together, and that's the only way we're going to be able to handle these things.
So, and Jeff, you get the last word. So, well, it's been a great discussion. I hope folks who have joined us today have enjoyed it. We certainly have appreciated your questions, and so thanks so much. And I wish everybody well. Take care.